Well, welcome everyone to the Better Breathers Club through Sarasota Memorial. I'm Angie Anderson. I am the program coordinator for COPD. And today we have a guest speaker who's part of our program, April Shin, who is the coordinator over at the Lung Health Clinic. So I'm going to move it over to her. And if you have any questions, we'll have questions at the end of the presentation.
What's April's last name?
Shin.
S-H-E-N?
There we go. Okay.
Okay. It says Angie, but my name is April. April Shin.
Hi, April.
Mr. Franco, can you see our screen okay?
No, I see your face, April.
All right. So Angie, how do I go to the,
You can go just hit next to each one.
Oh, I see, below that, I see Sarasota Memorial screen. I don't know if that's what you're talking about.
Yep. Can you guys see that okay?
The drawing of the picture of the lungs?
Yep, that's it.
Yeah.
Yep.
You want to go to
Yeah. Yeah. Oh,
How's that?
I'm on the right side.
All right. Hey,
If you mute your video, then
Right,
you will
you have
pop up when you move around. If you mute yourself.
okay, so I can't see those things. Okay. All right. Well,
I'm gonna take it back to the other view.
no, because they can see all the comments. I mean, I can see them. That's okay. All right, you want to stay in or you want to take over? Just the lines. Okay, hey, I'm April. I'm a nurse practitioner. I have, let me just kind of start with a little bit of introduction for me and for Toby. So I am a board certified master's prepared nurse practitioner. I have worked with Sarasota Memorial since 1995. Graduated with my RN license in 2001, my nurse practitioner license in 2014, and I started over at the Lung Health Clinic just last year. Then of course COVID hit, and you know, we've been a little slow to get the clinic up and running again. So here we are. Miss Angie, I've been participating in the Better Breathers Club, you know, just as kind of a listening member for the last year. So I feel like I've gotten to know some of you, like Mr. Franco and Mark and a couple of the others. So welcome to this month's meeting. Like I said, we work over at the Lung Health Clinic. So the Lung Health Clinic is me and Toby.
Hello.
You guys have met Toby before. He's
Yep.
as our respiratory therapist. So the Lung Health Clinic operates just across the street from the main hospital, and we do post-hospital follow-ups and education. We do spirometry in the office. We care for the uninsured and the underinsured population. So that's who we are. As far as my presentation goes, I know as Angie said to just kind of wait for questions towards the end, but you know, I try to keep it as casual and informal as I can. So if you have a question, you know, feel free to chime in, but you know, try to keep the questions to short brevity. We've only got an hour. So I just wanted to kind of start with this first slide here and just show you some of the education that we give our COPD patients in the clinic. You know, I'm just going to change this around just a tad. There was there's a way that I could get a pointer up here. Am I going to get pointer? Yeah. I'm not sure. I found a way to do like a little laser pointer, which was fantastic, but
Can you see the cursor? Can anyone see the
Yeah.
arrow?
remember how to do it?
Yeah.
You can see the arrow? It's on the bronchial?
Yeah.
Okay. you can
Okay,
see the
we'll just
cursor.
do it that way then. Okay, so this side of the slide represents what a healthy lung should look like, and you'll see that the bronchioles are nice and smooth. The alveoli, which is the functional unit of the lung, is nice and compact. As you know, the air travels, the oxygen travels down through your trachea, branches it off into the right and left lungs. Should be a nice smooth transition. And then the oxygen gets down to these alveoli where it exchanges with the blood supply that feeds the lungs, picks up the oxygen, drops off the oxygen, picks up the carbon dioxide and expels it. So with somebody that has COPD, for some patients, their bronchioles are narrowed, they're blocked with mucus, they're scarred. For some people, their alveoli are disrupted and they lose their elastic capabilities, and they just don't function as well and creates an airflow obstruction, hence the obstruction in the chronic obstructive pulmonary disease. COPD, you know, is a progressive disease, and it causes chronic obstructive changes in the lungs. We know that over the course of all of our lifetimes, whether we have COPD or not, there's a natural decline in our lung function. But with COPD, that decline is hastened, and we have to do our best to try to avoid the things that irritates our lungs. Primarily things like smoking, any sort of occupational exposures. We need to make sure you get treatment for your alpha-1s if that's something you've been diagnosed with. So we know with that obstructive process, some patients have difficulty clearing the lungs of any sort of dust and bacteria, any sort of pollutants or pathogens that they come in contact with. So as we go through this, I'm going to clarify a lot of the things that I'm saying. So I've tended to go with more of a medical type perspective for this, just because I know that a lot of you guys are really savvy with your disease processes. So if I get ahead of you guys, just let me know and I'll start again. So that difficulty in clearing the bacteria and the dust and the pathogens puts patients that have COPD at a high risk of infection. So that's why we wanted to talk about this today, just to prevent, so that you guys can recognize how these pathogens come in, or what you can do to prevent them, and then what the treatment is thereafter. We know that that respiratory infections don't necessarily cause COPD, but they definitely can cause those patients that have COPD already to flare or to exacerbate. And we know that if you have frequent respiratory infections, that they can cause more scarring in the lungs and enhance the obstruction, making your COPD worse. So when I refer to the term pathogen, there's a whole lot of different things that can be pathogens, but pathogens are those things that enter the lungs that create disease states. Those things can be viruses, something as simple as the common cold, influenza, heaven forbid, the darn coronavirus, any sort of bacteria, any sort of fungus. If any of those enter the lungs, it creates an inflammatory process and sets you up for infections. So I get asked frequently, how do I know if it's an infection? And this slide kind of represents what we as providers look for in terms of the ways to treat patients with respiratory infections. If you call me and tell me that you're more short of breath, it makes me question whether you're having a COPD exacerbation or whether you have an infection. And the things that I'll be looking for, or your doctors will be looking for, is well, we should ask about your phlegm production, your sputum production. So has the sputum gotten worse? Is the volume increased? What does it look like? So I put these 3 stars here by the purulence. And I just want to explain what that means. So when you're coughing, and I'm sure most of you cough in the morning, that color should be white to clear in the morning. And if it's any other sort of color or consistency, if it's green, yellow, tan, whatever it might be, if it's thick, if it's sticky, if it has a bad odor or a bad taste in your mouth, something's going on, and you should recognize that as a sign that you should get help. Another one of those things that I get asked quite frequently. There's a lot going on in this slide. There's a lot of information here, so we're going to go through it kind of one by one, okay? So as providers, we're going to treat pneumonia and bronchitis a bit different. So the pathway is quite similar for both. That pathogen, the viruses, the bacteria, the fungus, whatever it might be, enters the upper airways, gets down into the lungs. And in both cases, that pathogen causes inflammation. You can refer to this picture up here in the upper right. You'll see that there's a pictorial of what the inside of those bronchus look like. And that bronchus is lined by a smooth layer of mucus glands that help lubricate the airways. But when they're inflamed and they're exposed to any sort of irritants, including cigarette smoke, they will start secreting more mucus. They also become irritated and inflamed, and all of a sudden you have a smaller, narrow airway that you're breathing through. Now, that process is the same, whether it's pneumonia or bronchitis. The problem with pneumonia is it weakens your immune system, and that fluid, that phlegm, that mucus tends to stagnate. And when the fluid and mucus stagnate, it becomes potentially infectious, especially if with the virulence of the power of the pathogen that you've inhaled. And it can certainly cause the symptoms that you're all, I'm sure, well aware of: fever, cough, shortness of breath, increased phlegm production, chest pain. So you should be very wary of any of those symptoms. Now with bronchitis is in the acute short-term phase, will cause that airway to narrow. You'll experience some wheezing, some chest tightness, some shortness of breath. Bronchitis can, not always, but can resolve itself without antibiotics, without steroids. However, when you have COPD, those acute bronchitis phases can lead to a COPD exacerbation, and you need to be cautious and make sure you tell your doctor. Patients that have bronchitis for at least 3 months of the year for 2 consecutive years, we can deem those patients as chronic bronchitis. And those chronic bronchitis patients will develop some scarring and some obstruction in the lungs. And that is when we can qualify them as a COPD, chronic obstructive pulmonary disease patient, and treat them accordingly. So bronchitis symptoms, very similar to pneumonia. Usually bronchitis, you don't tend to get the fevers as much as you can, as much as you can with the pneumonia. However, when you're in that chronic phase of bronchitis, it can certainly cause you to have a lack of energy. You can even lose weight with it, and your risk of respiratory infections goes up significantly. We're not going to go into this slide in any sort of great detail. I just kind of gave you a sampling of some atypical type infections that COPD patients can be exposed to and live with in a chronic state for a significant amount of time. This is kind of beyond the scope of this particular lecture. But the one thing you should know, if you have any sort of exposure to these or you're infected with these atypical pathogens, you would be treated by an infectious disease specialist, and those treatments are tailor-made just for that patient. So I just said this word, and I'm not sure if you're familiar with it or not, but it's virulence. Another one of those words that I want to throw out there to you guys because I know you're medically savvy and you're trying to increase your education. So virulence is a pathogen comes in, whether it be that bacteria, that virus, that fungus, whatever it might be. How severe is it? How bad is it? How powerful is it? And what kind of effect is it going to have on your body? Now that pneumonia and those bronchitis that we just talked about, if you leave them untouched and if you leave them untreated, not only is it going to lead to a COPD exacerbation, but it can certainly lead to respiratory failure, hospitalization, the need for intubation and ventilation. And I'm sure you guys are well aware that when you have COPD, that ventilation process is difficult. And it's really hard to get COPD patients off of ventilators once you get them on. So we really do try to keep patients out of that severity of illness. Two of the major complications if that bronchitis or that pneumonia goes unchecked is lung abscesses. It's when that fluid becomes very stagnant and very thick, and it's very hard for it to be expelled from your lungs. It can create a disease process called an empyema, which is a very thick mucus that it's just impossible to expel. And oftentimes that leads to surgical procedures. Hence, get your pneumonia and your bronchitis treated before it gets too bad. The other thing that untreated pneumonias and bronchitis can do is lead to bloodstream infections, which would require an intravenous line, something similar to this picture, and long-term IV antibiotics, which is sometimes more than 6 weeks. So what can we do to help prevent infections? You know, we have to go back to that old adage of an ounce of prevention is worth a pound of cure. I always like that one. So what do we do to not get sick? I'm sure you guys have heard these quite a bit in the news lately. Hand hygiene. Wash your hands. The hand sanitizer's got to be a high percentage of alcohol. Make sure you're doing some moisturizers in those hand sanitizers to avoid cracking and infections. You see somebody who's sick, run the other way. Avoid them at all possible. You know, the face masks are eventually going to go away, you know, with COVID numbers lowering. But, you know, I'm a firm believer that they certainly are helping to prevent other sorts of infections too. Our flu numbers this year were quite low, and they are attributing those to face masks. Social distancing, you know, some of this stuff I hope kind of stays around. If you're sick, stay home. If you're sick from, you know, stay home from work, whatever it might be. Try to maintain your sickness at home. For COPD patients, we know that we're trying to help expel some of that, the dust, the pollen, the bacteria, whatever it might be, to try to keep your airways open is a great prevention tool. Like using that IS there as an incentive spirometer. You oftentimes get those in the hospital, but certainly using those at home will help keep your airways as open as possible.
Wait, what is that?
An incentive spirometer.
Incentive.
Yep. Incentive
That's
spirometer
something.
is a little tool that has a mouthpiece on it, and you inhale. It brings a valve up, gives you a measurement of how much lung volume you have, and it expands your airways. Creates enough pressure into the bottom parts of your lungs so that you can cough and get that mucus up. A PEP valve, I don't know if you're familiar with that, but a PEP valve also, they come by several different brand names. Aerobica is the one that we use in the hospital. It's a valve that you can use sometimes in line with your nebulizers, but it helps create enough turbulence in your airways that it will help expel some of that mucus that builds up. And certainly, never underestimate the power of just some simple coughing and deep breathing exercises to get some good fresh air into your lungs and get the mucus out. Avoiding smoking, secondhand smoking, avoiding other sick contacts, pollens, dust, animal dander if that's something that you're triggered by. And we all need to be careful with this red tide potential this year. If you're living anywhere close to the water, if it's red tide, make sure you're sheltering in place, you're staying inside, try to avoid the irritants as much as you possibly can. Drinking plenty of fluids will help manage the secretions. Trying to eat a diet higher in protein will keep you healthier in general. You're healthier in general, when you come in contact with these pathogens, your body has a better ability to fight. Staying active helps remove some of that mucus. And, if you have any equipment at the house, whether it be that spirometer, whether it's the PEP valve, a nebulizer, a CPAP, whatever you might have, portable oxygen concentrators, make sure you're changing those tubings out and cleaning them as instructed. That will certainly help keep the pathogens down. All right, everybody's favorite subject. Some people believe in them and some people don't. But I'm a firm believer. Now, for COPD patients, qualify for 2 different pneumonia vaccines. If you're under the age of 65 and have a special situation, i.e. lung disease, cigarette smoking, COPD, you qualify for a pneumonia. It's a valent 23. So you can have that under the age of 65, and then once you turn 65, you get another one. And if you're under 65 and are immunocompromised, again, the COPD, liver disease, alcoholism, cigarette smoking, whatever it might be, you also qualify for a second pneumonia vaccine. They've been proven quite effective in preventing pneumonia from even starting. Of course, flu shots once a year. And COVID shots are here. I heard this morning that 50% of Americans are now vaccinated. It'll be very interesting to see what happens next year, to see what the instructions are, and if we're going to have to have booster vaccines or whatever. I'm sure that they're not. I'm sure that they don't have the information yet. More to come. All right, so we've gotten all of this information. So what do you do? You've gotten a sick contact. You've, the neighbor kid came over and had a runny nose, and now you're not feeling so good. What do you do with it? The COPD action plan is something that Angie gives out to all of our patients in the hospital. I share it with my patients in the clinic. We like to really keep our patients in this green is good area. When you're breathing without shortness of breath, you're able to do your activities, you're sleeping good, your appetite's fine. And when you're in that green is good area, you're taking your maintenance medications, you're getting your exercise, you're not smoking. This is where we like to keep you at. This red area is what we want to avoid. Severely short of breath, not able to do any of your activities, you're short of breath even at rest, you're having to use your inhalant medications more often, you've got chest pains, you're talking about purulent phlegm. At this point, there's not much that we can do from our offices. You just gotta have to get yourself into the hospital. Where your outpatient providers, your physicians, your nurse practitioners, your physician's assistants can help you best, when you come in contact with one of these pathogens, or even if it be a a pollen or something that triggers an asthma-like symptom, if you call your doctor in this yellow section, this cautionary section, you're short of breath, you maybe cough more than usual, don't have as much energy, your mucus is a little thicker, your appetite's not so great. If you call us then we can affect some treatments. We can call in steroids, we can call in antibiotics. We can give you some instruction to keep you out of the urgent need for the hospital. So my advice is don't wait. Don't hesitate. Call your doctor. When you call your doctor, though, I want you to pay heed to some instructions. When you call your doctor and say, I don't feel good, doc, I feel sick, that doesn't really give us a great idea of what's going on with you. So I want you to take a list of your symptoms and give us some really good, solid information. If you have a thermometer at your house, take your temperature. If you have a pulse oximeter, take your heart rate, take your oxygen saturations. And then give us a list of what's going on. Is your cough worse? Is your sputum thicker? Is it colored? Is it, are you breathing heavy? How short of breath are you? Those are the things that can really help. So from our offices, we can call in those antibiotics, those steroids, order some labs, order some radiology, whatever it might be. So these are those symptoms that I'm talking about. This is what I want you to keep track of so that you know what to tell us when you call. Are you short of breath? Are you coughing? Are you wheezing? Are you tired and dizzy? Are you confused? What's that oxygen saturation? What does your mucus look like? Does it have an odor? Does it have a taste? How often are you using your short-acting inhaler? If your temperature is over 100.4, that is actually considered a fever, and you should definitely be calling your doctor. Or any unexplained weight loss. All right, so you've called your physician. What's going to happen next? Physician, may do a telehealth with you right now. They may bring you into the office. This first line under diagnostics, this clinical picture is the conversation between the provider and the patient. The provider, the physician, the physician's assistant, the nurse practitioner will want to listen to all those symptoms. They can oftentimes treat you just on that clinical diagnosis, on that clinical information. They may, depending on what those symptoms are, prescribe you an X-ray or a CAT scan. They may send you for some labs. They may send you for a blood draw, which includes a complete blood count. This tag here, this EOS is short for eosinophil. It'll give us an idea of if you're having some allergies that go with your infection. It's a reactive, whether you've been exposed to an allergen, like a pollen, those kinds of things. This ESR and CRP are both inflammatory markers. It tells us what degree of inflammation is happening within your lungs. And procalcitonin will tell us definitively, and this is something that we use in the hospital to determine whether a patient's actually in just a COPD exacerbation or whether their bronchitis or their pneumonia is what's causing their shortness of breath. Sputum cultures are great in the hospital when you're going to be here for a couple of days, but they take at least 2 to 3 days to get good results on, and by then you're already on treatment. So sputum cultures are great in the inpatient setting and not usually so effective on the outpatient. So then you're going to expect some treatment thereafter. So as far as the inhalers and the nebulizers go, the best way to use those while you're waiting on your physician to call back or you're waiting on that appointment, pick up your rescue inhaler. You can use it, or your nebulizer. You can use that every hour on the hour for up to 4 hours, no more than that. And then a couple hours every 2 to 3 hours thereafter until you get some help. And let me tell you, if you're using it that often, you're going to get a high heart rate. That's also going to give you some some symptoms. Try your best to manage on your own, and if you can't, please, please, please just get into the emergency room. And then, you know, if you can manage to get the doc on the phone and get things rolling from the outpatient services, you know, some antibiotics, possibly, and we'll go through why those are prescribed, and some steroids as well. As far as antibiotics go, when we're treating acute infections, so short-term infections, you've gotten a case of bronchitis, maybe an early pneumonia, you should expect to be on some sort of antibiotic treatment if your sputum is purulent, so that it's thick, it's yellow, it's green, if you're running a fever. That purulence, that color, that quantity, the quality of it, whether it's thick, is going to tell us the most. We're going to use something called an antibiogram, which is a local version of what antibiotics work best for what bacteria is causing it. In our area, the antibiotics of augment and doxycycline, azithromycin, we find that locally those work best for our patient population. Some COPD patients have to take a lower dose of a daily antibiotic, something like a macrolide, like azithromycin or erythromycin. They don't work so great when you're actively smoking, and there's downsides. So when you take an antibiotic on a daily basis, it definitely increases your resistance to those antibiotics, and they just don't work anymore. The macrolides, the azithromycin and erythromycin, can cause some hearing loss, and they can also cause some heart rhythm irregularities. They've also only been studied for a year at a time, so the information is lacking there. They don't prove, for some patients they help, but they don't prove that they can reduce exacerbations. You may eventually need to have a specialized infectious disease expert if you really are in need of daily antibiotics. So when you're calling your physician and you've got all of these symptoms going on, you ask for antibiotics, you just need to be cautious of them. So there's side effects to everything you take, but antibiotics specifically certainly cause a whole lot of GI upset. We find that probiotics can help. When you're choosing a probiotic, they've got to be in the millions of units. A weak probiotic just isn't going to help. Yogurts are great, but not so high in the probiotic category. Can certainly develop allergies, and the more you take antibiotics, the higher potential you have for developing that allergy. We talked about the resistance. And I put in here in parentheses, especially if you cut that course of antibiotics short. So, antibiotics are really meant to get into those bacteria and completely obliterate, completely destroy them. And if you cut that, you start taking the antibiotics, feel good, you start cutting them short, it only will get into the capsule of those bacteria, and it changes them. It certainly changes the bacteria, but then they mutate. You haven't completely obliterated them. So hence the development of the resistances. And eventually, if you take antibiotics for an extreme length of time, or frequent duration, then you can certainly develop an immunocompromised state. Steroids are quite similar in terms of side effects, and something that have their place, but you need to be wary of. The whole goal of steroids is to reduce inflammation, and that inflammation happens when you get the pathogen into your lungs and it starts irritating the lining of your airways. There's essentially two different steroids that we use either inpatient or outpatient, prednisone and methylprednisolone. The prednisone is an oral version only. It's only a pill or a liquid. It's quite effective. The methylprednisolone is more potent than the prednisone, and it's an available injectable. So you can go into your doctor's offices and get a shot of it, or they can admit you to the hospital and give those steroids intravenously. Steroids are also in an inhaled form, either via nebulizer like budesonide, or any of your inhaled steroids that are in your maintenance inhalers. So, but when you're acutely sick, the guidelines are showing right now that you give just a 5-day course of steroids. For some COPD patients, they need a longer, slower version of a taper, and that taper can last 10 to 12 days, sometimes even longer if you're having trouble getting through the exacerbation. Some patients even take steroids on a daily basis. However, there again, got to make sure you're watching out for those side effects. Steroids are famous for creating yeast infections, either on your tongue, if you're taking them by mouth, on your skin or your urinary tract. They can cause mild side effects like headaches and nausea. It makes you terribly hungry. If you're not watching what you're eating, it certainly elevates your blood sugars. If you're taking them for a long time, you can develop osteoporosis, fragile, thin skin. It can cause some mental changes and psychosis. It can change your vision. So, we have to manage these things on a provider level with minimization. We don't want you on them all the time. For my patients in the clinic, if you have severe COPD or even moderately severe COPD, I like to make sure that you have what's called a rescue pack. So it's a standby prescription that your provider would call in, and it has an antibiotic prescription, has a steroid taper, has instructions of how to use your nebulizer, your short-acting bronchodilator. This doesn't mean that you get a little bit of a runny nose and you start your emergency rescue pack immediately. It's when those symptoms start: the chest pain, the increased mucus, the color, the quantity of your sputum. You don't want to wait too long, but you want to have it readily available. We all know that you tend to get sick on Friday evenings and Saturday mornings when the doctors aren't quite so readily available. So anyway, that's a rescue pack. I think this is one of Bob's slides. It's pretty good. He never wants COPD and all of these infectious processes to cause any sort of isolation and fear. We want you to we really do want you to live your best life. Keep doing what you love. It might take a few extra steps to prevent yourself from getting sick, but if you do them, you can certainly live a better quality of life. And we just want you to be mindful. Pay attention to what your body's doing and how it feels, and make sure you're communicating that with your provider, your healthcare team, so that you can better make a plan and keep yourself out of the hospital. All right, so we got word that we can start meeting again in person. I'm going to turn this back over to Angie so she can give you more of the details and what's to come.